Oh, Dr. Chen, so hello everyone. Can you guys hear me? You guys can hear me okay, right? Okay, sounds good. Thank you. So while Dr. Chen is figuring out the mic issue, we'll just go ahead and start the introduction because so Dr. Stephanie Chen is antimicrobial stewardship. Well, welcome to join the second episode of Up to Date. So the guest speaker today is Dr. Stephanie Chan. She's an antimicrobial stewardship, infectious disease, clinical pharmacist, and with Western Medicine, Honley Hospital. Little background about her: she earned a Bachelor of Science degrees in chemistry from University of U of I and Champaign in 2011, and she was graduate from UIC with a pharmacy degree in 2015, and she went on to complete a PGY2 pharmacy residency at Our Lady of the Lake Regional Medical Center at Baton Road, and that's in Louisiana. And she also completed a PGY2 ID specialty residency at Del Satan Medical Center at the University of Texas in Austin. As of right now, Dr. Chan primary interest area includes antimicrobial stewardship, treatment of the multi-drug resistant infections, microbiology, and rapid diagnostic testing. So today she'll be going over, some common, like a general overview of the COVID-19, as well as some like the most popular treatment of COVID-19 as of right now. So if you guys could, we do have a link to the pre-discussion survey. If you guys could fill that out while we are waiting for Dr. Chan, that'd be much appreciated. Let's see, I'm gonna. Oh, thanks, Michelle. And also, if you guys have any particular question you want to ask, feel free to spam in the chat right now. We'll be collecting them throughout the discussion. So, yeah, don't be afraid of sending those questions right now. You won't get lost. Dr. Okay, oh, just presenting. Nice.
Hi there. Can you hear me now? I'm trying to present my screen right now and also see if audio will work through my phone.
Yeah, the audio works and we can see your screen now. That's awesome.
Okay, perfect. All right. Well, thank you so much, Peter, for the kind introduction. And I apologize for the delay in being able to talk at first, just working out the technical issues. But just stop me anytime if you guys can't hear me or something is not showing up on the slide. But like Peter said, I am an antimicrobial stewardship and infectious diseases pharmacist at a community hospital, Huntley Hospital, that is part of the Northwestern Medicine system. And today I'll be presenting SARS-CoV-2 or COVID-19, which I'm sure all of you already know a lot about. And thank you. I know that there are some pre-prepared questions at the end, so I will also be answering those and any other questions that everyone has about the ongoing pandemic. So just to go over some background that all of you may already know from just the news and what's been published, SARS-CoV-2 is a novel respiratory coronavirus that emerged in late 2019 in Wuhan City in Hubei province of China. It is determined to be a sister virus of the SARS coronavirus that was the outbreak that occurred from 2002 to 2003. This disease is caused by the virus, or SARS-CoV-2 is the virus that causes the disease COVID-19. So there are a variety of sources that report different mortality rates for this infection, varying from 0.5% at lowest to 4% among all infected patients. It may be as high as 22 to 62% in critically ill patients based on some studies. The common presentation of this disease is 1 week of prodrome. So this includes myalgia, malaise, cough, low-grade fever, gradually progressing to difficulty breathing in the second week. So most of the times when we see patients actually coming in, it's usually after they've had 1 week of just not feeling right, and they're coming in because they really are having, at that point, shortness of breath that causes them to come into the emergency department. It's usually an average of about 8 days to development of dyspnea, an average of 9 days to onset of pneumonia or pneumonitis. It's unlike influenza in that it's not a sudden onset. The mean incubation time is estimated to be around 5 days after exposure, with a range of 4.1 to 7 days, and transmission can occur from an infected person via droplets, from coughing, although transmission is more likely in symptomatic patients than asymptomatic patients. So we actually have a lot of common coronaviruses that cause the common cold. These are known and been diagnosed in the past. So these include alpha coronaviruses and beta coronaviruses that can be detected and diagnosed via real-time PCR and other molecular assays. The common cold that are caused by these coronaviruses usually include symptoms like runny nose, headache, cough, sore throat, fever, and malaise. Some more severe presentations cause lower respiratory illness and can be seen in the very young or the very old, or those with weakened immune systems. With the novel coronavirus, or COVID-19, caused by SARS-CoV-2, the illness can also range from being mildly sick or asymptomatic to severe illness and death. The symptoms are similar to the common cold in that it's fever, cough, and shortness of breath. So as for clinical care of patients for confirmed or positive COVID-19 patients, the spread occurs, as I know you guys have all learned, person to person via respiratory droplets among close contacts. Close contact can occur if you're within approximately 6 feet of another person for a prolonged time. Also, having direct contact with the infectious secretions from a COVID-positive patient. So infectious secretions include sputum, serum, blood, and respiratory droplets. So detection of COVID-19, currently, for the most part, labs are using real-time reverse transcriptase polymerase chain reaction, or PCR, of nasopharyngeal swabs. There are other modes of transmission, as was published by Wang and others. In this study, they looked at 1,070 specimens collected from 205 patients with COVID-19. This was in China, with a mean age of 44 years and 68% being males. The presentation of these patients was fever, dry cough, fatigue. 19% had severe illness. And the results show that out of the different types of specimens that were COVID positive, BAL or bronchoalveolar lavage specimens showed the highest positive rate. So they were the best specimens to collect to get a true positive. After that was sputum samples, then nasal swabs, then fibrobronchoscopy brush biopsies, then followed by pharyngeal swabs, then feces, and then blood. And they did test urine samples, and none of them came back positive. So transmission by respiratory and extra-respiratory routes may help explain the rapid spread of disease. And additionally, testing from multiple sites may improve the sensitivity and reduce the false negative test results for our patients. So for hospital preparedness, what I can tell you about our hospital and the whole Northwestern medicine system is that all different specialties and groups, infectious diseases, pulmonary, critical care, just everyone in the hospital has been working very hard and well together to come up with guidelines. And there have been many publications. This one from JAMA published March 11th about caring for critically ill patients. So as you know, there are no FDA-approved treatments for COVID-19, so really it's supportive care. And then there are a number of drugs that have potential based on studies that have been done, but nothing through a randomized clinical trial as of yet. but we will be talking about that in a little bit. So some of the patient information that we, give to our patients is that the best method to prevent illness and avoidance is avoidance of exposure to the virus. So as you all know, social distancing has been touted over and over again, and is why we are currently in a shelter in place in Illinois to really prevent the further spread of this virus. So of course, avoiding people who are sick and stay at home when you are sick, not touching your face, so your eyes, nose, mouth, covering your cough or sneeze by coughing or sneezing into your elbow, following the CDC recommendations for using a face mask, so really just using a face mask if you are symptomatic. Hopefully preventing spread to other people, and then washing your hands. So hand hygiene is extremely important, and making sure you wash for the proper amount of time, at least 20 seconds, so that any viral particles or any exposure you can clean off of your hands. As of now, there is no vaccine available to prevent COVID-19, though there are studies in progress, and the estimated time before a vaccine would be approved at the earliest is 12 to 18 months. As for patient management, since we are seeing more and more patients every day coming in, having to rule out COVID-19 or true positives, for those with mild illness, we're encouraging patients just to stay at home and contact their healthcare provider by phone or electronic means. If they do have severe symptoms, such as difficulty breathing, then they are to seek immediate care, but we do recommend that they call the emergency department or their healthcare provider first before going in, so they can be prepared to put in droplet precautions for that patient. And then for older patients or those with underlying conditions, such as those that are immunocompromised, contacting healthcare providers early and going in to see the physician or going into the ED and being admitted if needed. So patient criteria for screening, it continues to change, and this is just what was posted on the CDC website as of March 8th. But basically, you work with local and health state departments to coordinate testing. As of now, there are private labs, such as LabCorp and others, that now provide COVID-19 testing. For us, triaging in the hospital setting, we look at the patient's presentation and whether it's compatible with COVID-19 before, obtaining a sample and sending that for testing. We do have to prioritize patients, obviously, since, as we know, there was a shortage of test kits and even nasopharyngeal swabs, and it is kind of ongoing and a changing day-by-day issue. So hospitalized patients with signs and symptoms of COVID-19, of course, are probably going to be higher priority than those who are asymptomatic but believe that they have had exposure. And of course, as healthcare workers, we have to be very cognizant of the proper PPE that we need to wear when entering a room with a potential COVID positive rule out. So we call these patients PUIs, or persons under investigation. We use contact precautions for them per the CDC guidelines. And if the patient is positive and we need to do a aerosolized generating procedure, then we do go with airborne precautions, which includes the N95 mask. So for the laboratory tests, again, this may already be a little bit outdated since every day things are changing as far as testing goes. So there have been emergency use applications granted or pending for various diagnostic tests. You can see some of the ones here that have been approved or are pending. Like I said, private labs such as LabCorp have already developed their own and are taking samples for testing. So as for treatment options, this is an evolving subject, of course. There is no proven therapy for the novel coronavirus at this time. Therapy is predominantly supportive care. There's no specific antiviral that is known to be effective, though there are several studies being conducted, and there have been previous retrospective studies and other studies that looked at it. Some agents were used in China or are still actively being used in China, which is where a lot of this data comes from. So some of the drugs under investigation include remdesivir. This is a antiviral agent that was used previously for Ebola, developed by Gilead, which is currently going clinical trials. Hydroxychloroquine and chloroquine are antimalarial drugs that have also been shown in some studies to possibly have some effect for the coronavirus that is now being used and studied as well. And then there are some other agents that have some evidence that for use as well, including tocilizumab, also known as brand name Actemra, and serlimumab, brand name Kesvara, as well as lopinavir, ritonavir, or Kaletra, and many more. So I'm just going to go over a couple of these drugs, and of course, if you have more questions on them, I'd be happy to answer what I know of in the literature that's out there. But again, none of these have been proven effective against coronavirus at this time. So one of the ones most talked about probably in the media is remdesivir, a drug by Gilead Sciences, also known as GS5734, which is a broad-spectrum antiviral. It is an IV medication that was previously tested in humans with Ebola virus disease. It also had shown promise in animal models for treating Middle East Respiratory Syndrome, MERS, and severe acute respiratory syndrome, SARS. So there are several clinical trials in progress, including one with remdesivir versus placebo, which is an adaptive clinical trial that's being done at Northwestern Memorial Hospital. And it's being studied as a IV medication with a 200 milligram times once initial bolus, then 100 milligrams daily times 10 days. As far as the literature goes, there was the case report on the first COVID-19 patient in the U.S. that showed improvement with treatment using remdesivir. So there is a lot of hope and speculation that hopefully we'll have some results that can help us treat these patients once the clinical trial is finished. So hydroxychloroquine, also known as Plaquenil, is another drug that has been used in an attempt to treat coronavirus. So both chloroquine and hydroxychloroquine are antimalarials with immunomodulatory effects. So in an in vitro study, chloroquine was found to inhibit growth of SARS-CoV-2. Again, this is in vitro. Hydroxychloroquine is a derivative of chloroquine with drug-drug interactions as well as chloroquine, but in some studies it's shown to have a more potent pharmacological effect than chloroquine. And previous studies from SARS outbreak also showed that hydroxychloroquine had some activity against SARS-CoV-2 in vitro. So in one study in vitro, again, there was a dose determination to use hydroxychloroquine with a loading dose of 400 milligrams twice daily times 1 day, and then 200 milligrams twice daily for 4 more days. And that's what we are seeing used right now in our hospitals, though the dosing is also subject to different debates as far as what is most effective. Lopinavir, ritonavir, or Kaletra is an HIV medication that includes 2 protease inhibitors and a booster that was hypothesized to block replications of SARS-CoV-2. It is not approved for this indication, but it had some in vitro efficacy studies that seem to have some hope for it. However, as of March 18th, there was a large randomized control open-label trial published in New England Journal of Medicine that concluded that there was no benefit observed with Kaletra beyond standard of care for patients with severe COVID-19 disease. So that's all I really had. I know that was kind of quick, but I want to save time for questions and audience questions. here are the references that I used, and I wanted to thank some of our other ID pharmacists, Rashida Shah and Radhika Polisetti, for creating this original slide deck that I modified. So I will let maybe Peter present the questions next. I'm not sure what's the easiest way.
Yeah, for sure. So we actually do have a question from the audience. I don't know if you want to answer that about. It's about the guidance on the use of gloves outside the medical setting. Does it help or just increase the risk of infection? Oh yeah, you see the question now.
Yeah, I see it. So thank you, Daniel, for the question. So as far as recommendations on gloves, as far as I know, no specific guidance of people in the moving around outside the hospital with gloves. When we are in the hospital under contact precautions, we always wear PPE that includes gloves. So outside the medical setting, I don't think there's really much use. The only one I can really think of is maybe, if you tend to touch your face a lot like I do, that might prevent you from touching your face as much. But outside of that, I think really hand hygiene is most important, because in order to get the virus that you may have come in contact with in your hands, that's probably the best method. And I see the next question was, if N95 masks are not available, are there other masks used for some level of protection? So yeah, as you know, there's an N95 mask shortage, though we are seeing that other companies are stepping in to ramp up production. So in the situation that we run out of N95 masks, which knock on wood, right now we have not at our hospitals yet, we would have to use our normal surgical mask and possibly face shields in place if we were to not have N95. But again, those are nowhere as effective at preventing, airborne particles from transmission. So that would be only if we completely ran out of N95 masks. And I see another question. Thank you, Donna. Besides PPE supply shortages, are there any major drug shortages ongoing? So yeah, this is an evolving situation every day, and I'm sure every hospital administrator and pharmacy administrators are all trying to keep track of what's going on shortage. So some of the main ones are the ones that have the medications that have purported evidence for COVID-19 treatment. So hydroxychloroquine, chloroquine are all on shortage. Remdesivir obviously is not approved, so there's no availability of that unless you're going through the clinical trial or getting it through the manufacturer. Kaletra, or the lopinavir, ritonavir, is also on shortage, and those other agents that I mentioned, tocilizumab, Actemra, sarilumab, Kesvara, are also all going. Basically, what we're seeing is that anything with potential benefit for COVID-19 patients are being brought up at an exponential rate, and so patients who might be on hydroxychloroquine for lupus are seeing that they're having trouble just filling their prescriptions, which is very unfortunate because there are other indications for these drugs that patients need them for. Besides that, we are concerned with azithromycin because there's one study that showed azithromycin with hydroxychloroquine having some kind of efficacy. Again, it's also a small study with just a few patients, but people and hospitals are buying up azithromycin rather quickly. And then as far as other drug shortages related to ICU care, basically are sedation medications, so propofol, midazolam, some other agents are all also becoming short. And it's an evolving situation every day, so I wouldn't be surprised if more medication related just to patients in critical care go on shortage as well. So another question from Jessica, thank you. There was an article that stated that using NSAIDs was not recommended and acetaminophen should be used instead to decrease the fever. So if you have COVID-19, is it true and/or would you recommend the use of acetaminophen over NSAIDs? So yeah, that's a great question. There has been a number of different societies that have looked into this, and at this time, NSAIDs, which is ibuprofen, are kind of being not recommended if patients have the option between acetaminophen or, say, an NSAID like ibuprofen for fever reduction. As we know, NSAIDs in general have more side effects than acetaminophen. GI bleeding and other cardiovascular risks are associated with its use. So in general, we are recommending not to use NSAIDs in those patients if possible. But if you're using NSAIDs for other indications and you aren't being treated for COVID-19 or you don't have a high suspicion that you have the disease, then there isn't a specific recommendation to stop your NSAID. And then another question from Daniel. I'm not sure how much patient contact you have in your role at Huntley, but do you take any extra steps to make sure you do not contaminate your household? So yeah, that's a really good question. I'm sure everyone that works in a hospital or retail pharmacy setting, anywhere where you have patient contact, you're concerned about bringing it into your home. And I think that's a very good question, something that's on all of our minds as healthcare professionals. As far as what I do is basically I try to shower basically after a shift from work, and of course the first thing before I even leave work is wash my hands again when I get back from work. But I don't think there's any specific recommendations on top of that that I have. I think, just being a healthcare provider, we have to put ourselves kind of at risk, but all we can really do is perform hand hygiene, and try to stay away with those people, friends and family that are at higher risk, so that we don't potentially transmit the virus to them. I think that's all the questions I saw on the side here. If there are any other ones that come up, please feel free to just type them in, and I'd be happy to answer them.
Sure. Thanks, Dr. Chang, for that very thorough slides. And are you guys able to see the slides? Because I think I had an issue putting out the slides. Yes? Okay, that's good. So we have some prepared questions. Feel free to shoot more questions if you have more in the chat. So the first question we have is that being an ID pharmacist at your institution, how have your role or responsibility changed since the start of the pandemic? Because I'm sure, a lot of things have changed, and yeah.
Okay, sorry, I stopped presenting, so I'm not sure if you can still hear me.
Yeah, we can hear you.
Okay, sounds good. I don't know if I needed to share my slides or not. Okay, perfect. Let me just open up slides. My role at Huntley Hospital is mostly doing antimicrobial stewardship and, of course, helping ID consult service as well. As far as what I did before COVID-19 really exploded and what I do now, I think it has changed a lot and continues to evolve day by day. There's ever since the first few cases started coming into Illinois, basically the whole system, Northwestern Medicine, has been preparing with guidelines, recommendations, and whatnot with COVID-19 patients. Really, there's so many issues at hand, from the lack of PPE to how do we cohort these patients into negative pressure isolation rooms to, what are we treating them with when there's so little evidence out there. So a lot of my time, probably at least now 75% of my time, is spent just figuring out what we're doing with our COVID-19 positive patients, those who are getting ruled out. And I think so many people's roles have changed drastically because of this. I mean, we're basically trying to make sure that when larger influx of patients starts coming in, which is probably inevitable, that we are prepared, that we have the right protocols and procedures in place. And I think everyone at our hospital and the whole system has been doing a great job communicating with each other to basically streamline recommendations so that we're all on the same page for what we're doing when a potential COVID patient comes in, where we're isolating them, and that kind of thing.
Awesome. So let's see. So the second question is, I think we sort of, I think someone from the audience kind of asked that. It's about the shortage and the safety of the employees. I think we kind of touched base on that. Do you have anything else to add to this question, Dr. Chang?
Yeah, sure. So besides what I mentioned that are our national shortage, what strategies are hospitals employing to mitigate the issue? So interestingly, at our pharmacy department, and I think now slowly throughout the whole Northwestern medicine system, is that we're having Team A and Team B of pharmacists. So actually, I'm working from home today as the Team B pharmacist that works remotely. And basically, if we have pharmacists that fall ill or have to be in isolation due to contact with or exposure to COVID-19, then we come into the hospital basically. But for now, we're working, a team of us are working remotely until we need to be called in, so that we have pharmacists that are able to sub in basically and have not been exposed because they have not been at the hospital. I know that they're trying their best to just basically anyone who's not having to necessarily be in front of the patient work remotely so as just not to expose more of our staff as well. I think that's a really good strategy that's been put in place because once you have one exposure, there's a lot of people that have been involved with one patient that may have to be isolated at home. So basically, if anyone does get exposed, they're told to stay at home for 14 days in isolation, and then rechecking symptoms, fever, that kind of thing at 14 days to see if they're able to return.
Thank you. And also, we do have a question from the audience about the warmer climate. So I think it's asking, does the warmer climate will slow the spread of this COVID? I think he saw from the news, and is there evidence supporting that?
Sure. So yeah, that's a really interesting question. So a lot of people are speculating that possibly once the warmer weather summer gets here, that maybe we'll see a downturn in the number of coronavirus cases because like influenza, which is a seasonal infection, tends not to spread as well during the summer. But as far as what we know about this novel coronavirus, we have no idea because we've never seen it before. It's completely new. It could have a pattern similar to seasonal influenza, similar to the previous SARS 2002 to 2003 that kind of diminished, and then there was a second wave once fall, winter got here again. So it's really hard to say at this point. We just don't know, and it's probably not good to make any assumptions that we'll see a decrease in cases come summer. And as far as in relation to previous pandemics, I think there have been a lot of similarities being drawn to the Spanish flu back in 1918. So that was also across kind of two winter seasons that it really spiked. So it kind of decreased in the summer and then reappeared in the winter. And a concern with that is really if we let our guards down, if cases were to decrease in the summer, then we might get hit just as hard again once it reemerges in the colder months.
Cool. And I think, so I was kind of checking the question in the background. It seems like a lot of question was answered or asked by the audience already. So this was the shortage about the test kit. And we also have questions about this is also about like shortage, and this is about hydroxychloroquine, which you also mentioned. And I think the last question we have prepared is, do you have any prediction on the future forecast of this pandemic?
I would say I'm definitely I don't have a crystal ball for this pandemic, and I don't want to make any predictions. I think everyone that I've spoken to, ID physicians or other ID pharmacists, that we really just don't know. This is completely new, and it's better just to be prepared for the worst and continue to do our best to prepare than really predict what will happen. This shelter in place has been put through the beginning of April, but we have no idea if, depending on how many cases we have at that point, how much community spread we have, how long we'll be in this, in this situation. I know that we are really just starting to ramp up in cases. I think we've seen different waves. First one in China, then it came to the U.S. via Seattle, the whole West Coast. Now New York City has really just blown up, and we're kind of still early in the phase. If we do a good job of our social distancing, of sheltering in place, and basically really limiting our human contact and transmission of this disease, we can avoid something like Wuhan when it was at its worst. But we haven't seen the peak here yet in Illinois, so it's really hard to predict how this will go. And I think we all just have to be good citizens and, as best as we can, following the social distancing rules and the shelter in place that have been put for the safety of all of us.
Also, I think so because we touched on the hydroxychloroquine, I think we have I think we have a question about does hydroxychloroquine the using of hydroxychloroquine and erythromycin, because I think people are treating with those two using together.
Yeah, and I think that's a great question. So basically, there is one study. It was an open-label, non-randomized clinical trial with using hydroxychloroquine with azithromycin. It came out of France. And so just because basically they add on azithromycin, now a lot of places are clamoring to get azithromycin in combination with hydroxychloroquine. And I think it's a very correct note to be aware that there are drug interactions. So both of them, hydroxychloroquine and azithromycin, increase QTc basically cause QTc prolongation. So there's a concern there. And the data from that one trial that only had, I believe, 36 patients, was not very strong in seeing any kind of added benefit with azithromycin. I want to say that most of the ID pharmacists I've spoken to don't actually agree with adding azithromycin on top of the hydroxychloroquine, not only because the evidence is weak, but because of the interaction with the two leading to QTc prolongation. And then on top of that, I would say with hydroxychloroquine in itself, because of its QT prolonging effects, there are lots of different drug interactions that we have to be aware of, especially in patients on a lot of different home medications. So we're basically asking providers if they have prolonged QTc of 500 or greater to basically either not start the drug or monitor EKGs at least daily while they're on medication for COVID-19.
Awesome, thank you. I missed a question from Jeffrey. So Jeffrey also asked a question about there has been some news covered regarding how states are competing for medical supplies from the federal government. Can you comment or elaborate what exactly that means from your perspective, and how does that impact you?
So as far as states competing for medical supplies, I'm not as familiar exactly with how our hospital is obtaining those PPEs and medical supplies. Ours is more on the drug side of focus, but I think that it's incredibly important for our federal government to act and really use their resources to provide, what we need, ventilators, PPE, to the areas that are most highly affected at this point and figure out other ways to distribute the supplies we need. I think states competing with each other is just, wasting resources when really everyone's focus should be on just treating our patients, not trying to hoard as much PPE or equipment as they can and leaving other states, in a worse off situation. But again, I don't know exactly how it affects our specific institution and system because I'm not directly involved in supply procurement.
Yeah. So actually, like thank you, Dr. Chan. Also, like our next speaker, she's from infection prevention specialist at Chicago Department of Public Health. So our next speaker may speak from a different perspective about this question too. She will join us next Friday. Do you have any question from the audience? Because we all the questions that we prepared was asked or covered. If not, thank you, Dr. Chan, for joining us. We really appreciate your presence and taking part of your busy time schedule and to join us. And so we do. So like I said, for our next week, we have Amy Hansen, Dr. Amy Hansen. She is, like I said, she's an infection prevention specialist at Chicago Department of Public Health. And our next episode will be on Friday, April 3rd at 12:30 again. So if you guys have, does anyone have any remaining question for Dr. Chan before we disconnect? Yeah, and also we have posted the post-discussion survey. If you guys can fill that out, that'd be much appreciated. Just like things that we can improve, and because this is still our second series, we actually changed our form a little bit. We kind of shortened the presentation into trying to do it within like 20 to 30 minutes so that we can open the floor to the question. So if you guys have any comments about that or any discussion, feel free to posting the post survey. And it seems like we don't have any question right now. And thank you again, Dr. Chan, and thank you everyone for joining. Okay, and stay healthy and stay up to date.
Thank you so much, Peter.
You,
and if there are any other questions, please feel to email me, and I can try and answer them as soon as I can.
Yeah, sure. And I will. Is it okay to share your email with the
Sure.
audience?
Yeah. Why don't I send you my Northwestern email, and you can definitely share that with the audience.
Yeah, I will post the email in the chat shortly. If anyone has any remaining questions, I will do that shortly. And thank you, Dr. Chan, for joining us.
Thank you, everyone, for joining us.
Thanks.